Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is part 9 of an ongoing series titled COVID-19 Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 diagnosis, prevention, and management, each followed by an in-depth question and answer session designed to address infectious disease specialists' most pressing COVID-19 questions. During this episode, Dr. Lynora Saxinger, co-chair of the Scientific Advisory Group for the Alberta COVID-19 Emergency Coordination Center and associate professor at the University of Alberta in Edmonton, Canada, will provide a brief update on key concepts in COVID-19 immunity and the latest information on treatment strategies. For more information about Dr. Saxinger and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear a brief COVID-19 update and answers to clinician questions by Dr. Saxinger.
Well, I would say good afternoon, but I think we're spanning time zones. I'm very pleased to join you today. And when I was thinking about what we might do as a start to our question and answer session, I decided to include a few various topics, and starting with actually a global status update. The very useful Johns Hopkins dashboard shows us how many confirmed cases there were as of, I think, I might have actually looked yesterday, so I should have updated the date. But there's basically close to 30 million confirmed cases, and we know that that will underrepresent the number of true cases potentially quite significantly. And then I had a selection of countries showing the relative numbers with percent of global cases shown in brackets. Looking at the global deaths, again, this might underrepresent in various jurisdictions. We can see some countries actually have a similar ratio of confirmed cases and confirmed deaths. Others seem to actually have a lower number of deaths compared to the number of cases. And then finally, I think this is important also when we think about the global epidemiology, which is shifting very quickly. Given the global population, for example, the US is 4.2% of the global population with currently 23% of the global cases, and kind of so on down the line. Some of the places I think are interesting to look at are people are curious about Sweden. Sweden has only 0.1% of the global population, had 0.6% of the global deaths and 0.3% of confirmed cases, but nonetheless, the overall burden is relatively minimal. And then in China, I think where everyone first became aware that this can be a very, very serious epidemic, we have 0.3% of the confirmed cases in spite of having 18.5% of the global population. So obviously there's quite a lot of global variability in these numbers. I think one of the things that people are really keeping an eye on right now is COVID immunity. And this is an area also where a single study often comes out and people take the conclusions of that study as being kind of almost a given and maybe even overturning prior knowledge, whereas I prefer to think of all new studies as being another brick in our wall of knowledge, which may or may not change our prior ideas. I think one of the things I hear people talking about a lot is herd immunity and what's the end game of this process. So for herd immunity, most estimates based on the R0 of this infection suggest that in a naturally unfettered epidemic situation, we would need 60 to 85% of the population to be infected. But without containment, there's generally an overshoot. So if we just let the epidemic roll through a population, it's not as if it would actually stop after 60% of the population has been infected. It will keep on being an epidemic until it runs out of susceptible persons. And so there's always going to be an excess number of infections and deaths. The infection fatality ratio is, when you look at it very rigorously using serologic data, 0.6% to 1%. Now, this is different than the case fatality ratio, which is characteristically quite a lot higher and can range from 3 to even as high as 10% in some places. And that's really trying to look at true infections, not just documented infections. How many people are likely to die? The other thing about IFR is that it does increase significantly with age. And so with each decade of age, you have a higher infection fatality ratio. So it does vary considerably. That would work out in our situation in Alberta here, where we have 4.2 million people to 40,000 deaths. So that's about the same as the population of Los Angeles. And a person would on average know 6 people who died of COVID in our population should there be no attempt to contain the epidemic. So I think a lot of us feel that vaccination is the main hope. And the predictions, I think, for availability of a vaccination program by late 2020 seem over-optimistic. But I think that by early 2021, we may have more than one vaccine candidate being manufactured and available to start being used, likely in high-risk populations first. Now, this actually comes back to the question of COVID-19 and immunity. When we're trying to understand a new disease, we look for other examples. And when we look at SARS 2003, so that's a quite related virus with some clinical similarities, the antibody response seemed to wane quite a lot after the first 2 years, but T cell immunity seems to last much longer, 5-6 years, or even more than a decade. When we look at the cold coronaviruses, so the species of coronaviruses that make up about 15% of our common colds in the community, in many of those nuisance infections, the antibodies seem to wane over about a year, which is why you can get reinfected with multiple cold viruses. It's like the gift that keeps on giving. And in some coronaviruses, because there's a lot of coronaviruses that can infect other species as well, the T cell responses are quite durable, so they might be important in long-term immunity, but there are some cases where the T cell response can be immunopathogenic and actually cause problems, such as amplifying subsequent infection. So for SARS-CoV-2, the COVID-19 virus, we're learning as we go. It really does seem, based on data so far, that most people develop antibodies, including people with low-level symptoms, although there's some suggestion lesser symptoms may have lesser antibodies, but that's not consistent. Most people will seroconvert by about week 3 after the onset of symptoms, but there is a decline in antibody titer over the first few months, and that is not unexpected. And I think there was a bit of panic about that when some papers came out, but I actually don't think that looks anything different than what we would expect in a viral infection of this nature. And it does look like neutralizing antibody is produced by most people, even elderly people, in a recent study. So that all seems very promising from the point of view of vaccine, I guess, feasibility. But do antibody levels equal immunity? I'm just going to say that I don't think we can say that because we don't really know the correlates of immunity yet. Cold coronaviruses can reinfect when you have detectable antibody, although it seems like that might lead to less symptoms on reinfection. The other thing is, of course, we have these handy memory B cells, which can make an anamnestic response and boost your antibody level on re-exposure. So even though the antibody titer might have dropped, you might still be protected regardless. And we don't have that number yet for what protection means. And of course, T cell immunity might be playing an important role in many coronavirus infections as well. Another thing I think that's of interest, and we'll probably learn more about, is mucosal antibodies, so IgA antibodies. Because they're on the mucosal surface, that might be a vaccine consideration to try to reduce the incidence of infection, whereas circulating neutralizing antibodies are more likely to reduce the manifestations of disease upon infection. So that's another area I think that we'll see development, and it might end up being that we have vaccine strategies that include different types of vaccines eventually. Now, people panicked a bit with the suggestion of COVID reinfection. I think that now there's actually more than 3 reinfection cases that have been discussed by public health agencies. So there's been some in the Netherlands, Belgium, in Nevada, and then this first case in Hong Kong, which I described in a little bit more detail here. I'm actually just getting someone to maybe get my dog away from my door. I apologize. Working from home today. So in this case, an individual had tested positive with some symptoms, which were fairly mild, and then 5 months later was found to be PCR positive again on return from travel. And there was no antibody response detected 10 days after the onset of infection in the first instance. And then 5 months later, when it was found to be a new infection, they did find an antibody response 5 days after the possible reinfection was documented. So, you know, no test is perfect, and there have been well over 23 million infections. This seems to be a robust documentation of reinfection because they sequenced the virus and it was different. And so when we look at the number of infections that have happened, I don't think it's really that unexpected. There would be occasional reinfections. We just don't yet know if this will be a small minority of people or if this is going to become a theme and we're going to see limited immunity from natural infection. And so the other thing here is that we often are asked, in people who've had COVID, whether they still need to take all the precautions. And I would suggest that yes, we should continue to tell people to take precautions, even though they might be tempted to think that they're protected. So I'm just going to quickly point to a handy list from the American Society of Hospital Pharmacists, where they update quite frequently the evidence for COVID-19 related treatments. And I think this is a nice resource for a quick look at what is known. I'm just pointing to some that I think have been getting a little more press lately. We're going to spend some time talking about corticosteroids. There's been a new press release, but no trial data yet on the use of baricitinib plus remdesivir. We're going to talk about remdesivir some as well. And I'm not going to talk about it a lot, but another area of active interest, of course, is convalescent plasma. Just looking back to the past, though, and thinking about things that we have learned, hydroxychloroquine really does, on a repetitive basis now, appear not to be useful, but it has been quite a dramatic saga. I think that there are some dangers of desperate polypharmacy and of observational trials done with poor endpoints. We had some underpowered randomized trials, which I think were suggestive. Then we had the possibly falsified data and a lot of Twitter hype and discussion and I guess controversy around whether or not this medication works. But really through late May and early June, multiple trials were halted because of the Oxford recovery, including the Oxford recovery trial hydroxychloroquine arm. And then at the same time, more robust data was coming out, which really did suggest that hydroxychloroquine is not having a beneficial effect in randomized controlled clinical trial data. And so I think that that has made us all a little bit more leery, I think, of it quickly adopting investigational therapies. Remdesivir and dexamethasone, I think, are areas where there's quite a lot of good and evolving data. So remdesivir is currently, at least in our setting, available in clinical trials and through expanded access programs. Mortality benefit, I think we're still waiting on the ACTT data to clarify. And most of the data currently is supporting reduced recovery time using the WHO ordinal scale, which really kind of looks to time to being well enough to leave hospital on a practical basis. And overall, the biggest benefit appears to be in people who are receiving oxygen, so standard oxygen without the need for invasive ventilation. And there is not as strong a signal as improvement in people who are more severely ill. Likewise, in the simple moderate trial, the odds ratio for day 11 clinical improvement was also improved in the remdesivir group. And I think colleagues in the area who are involved in the trials are tending to think that the benefit of the antivirals is probably earlier in disease, whereas the benefit in corticosteroids is most likely related to the inflammatory later stages of disease. And so the dexamethasone story really started from early reports from China, Italy, and Spain, where steroids were part of many combinations that were being used. The recovery trial from Oxford really gave us better data that the 28-day mortality rate ratio was improved in dexamethasone patients, particularly those on oxygen and very particularly in those who required invasive mechanical ventilation. One note is that in patients who are not receiving oxygen, the possibility of harm was not excluded by their data. And this is not an entirely benign medication. In that trial, investigators decided whether or not the patient had any potential risks from dexamethasone and decided whether or not to enroll them in the trial. So the most recent thing is really interesting because 3 clinical trials of steroids came out at the same time as a meta-analysis put together by the World Health Organization in JAMA. And it basically tried to more extensively look at the question of steroids, particularly dosing and different types of steroids. And I think that the results are pretty compelling that overall steroids do improve disease in critically ill patients with COVID-19. It does appear to be across different steroids, including hydrocortisone and methylprednisolone and dexamethasone. I think the strongest data still lies with dexamethasone, but there's no reason to expect that the other steroids would not work. And as a consequence, there's NIH guidelines, there's IDSA guidelines, there's WHO guidelines. The IDSA guidelines point out that we should not use hydroxychloroquine or chloroquine, that remdesivir should be used in a trial, or if available, through emergency authorization, consider a 5-day course for patients on supplemental oxygen, and to kind of consider earlier therapy if possible. And then dexamethasone or equivalent doses for ventilated patients with severe COVID-19. And that can also be considered for those requiring oxygen but not ventilation. And then convalescent plasma, monoclonal antibodies, tocilizumab, and other antivirals should probably be considered mostly in the context of a trial. I think the rationale for that is that because we have quite a lot of pandemic left, unfortunately, the faster we can get high quality data on optimizing treatment, I think the better it is for all the patients who are going to be facing this infection. So the WHO Living Guidance document is summarized here, corticosteroids for COVID-19, pointing to critical COVID-19. So this is basically people requiring ICU support. And because I like oversimplifying things, severe COVID-19, which is really defined by respiratory distress and requirement for supplemental oxygen, there is a recommendation for corticosteroids. For non-severe disease, like for example, for outpatients, there's no suggestion for corticosteroids presently, but I'm sure that we will actually learn more as time goes by. So I think we can move into the question and answer period.
Great. Thank you, Dr. Saxinger. Yes, we've had quite a few questions, so we'll get to as many as we can. The first one is there any evidence that there's variability in the severity of infections related to different strains of the virus? Jeanette would like to know.
I think the short answer is no. There's kind of a longer answer because people have been looking for strain difference or evidence that the virus has been, mutating over time. We can actually, of course, track the degree of mutation over time, and there's a website that's doing that, but the mutations that are accruing are very minimal and don't appear to really affect the clinical outcome that much. There's been a tickle of information that maybe there's been some spike mutations that might end up affecting disease, but I don't think it's really significant enough to change our management or our impression of COVID-19 at the moment.
Great, thank you. Ahmed has a question about the use of steroids, and they're wondering, is the use of steroids at high doses indicated for severe COVID? So question about dosing.
That's a good question. So in the randomized trials that were put together recently and in the Oxford trial, the dexamethasone dose is relatively modest. And in some of the other trials, they evaluated high versus lower dose steroids, including kind of more of a physiologic stress dose versus a pharmacologic dose of hydrocortisone. And in that case, although both doses had an effect, the higher dose appeared more effective. And so I think, although we might see some more work on dosing at the moment, we're looking at kind of, I would call it moderate dosing of corticosteroids. So the dexamethasone 6 milligrams a day or equivalent would be where we would tend to recommend right now.
Great. Okay. We've got a couple of people who've asked for your thoughts on the use of convalescent plasma in the management of symptomatic patients. Current opinions are conflicting and confusing. So maybe you could share your thoughts on that.
I would endorse the conflicting and confusing. There have been a number of trials, but they're all kind of small and they do not necessarily give a strong signal one way or another. I think there's certainly enough data to support that convalescent plasma could have a role. But I mean, the largest amount of data we have was done in an uncontrolled observational fashion. And so there's certainly limits to the conclusions that can be drawn from that. So although I think that it's completely appropriate to continue studying it, I'm not sure how much it will actually end up benefiting, for example, compared to the use of medications like steroids or earlier use of antivirals. So it's a contender, but I think that it's not clear yet.
Okay, we really need a randomized comparison to know. Yeah. Okay, great. The next question is about the use of anticoagulants. So participant wants to know, are they, at what time, I think they mean what time point in the disease course would anticoagulants be indicated in COVID? And when would you select therapeutic versus prophylactic dosing?
Okay, so I'm going to answer from the perspective of an ID doc, so take that with a grain of salt. But my impression of there was a great deal of interest in the pathophysiology and the prothrombotic cascade as part of inflammation, in the kind of medium days of COVID. And as a result, a lot of people actually were anticoagulated. I think that where it's been leveling off is more that the threshold to anticoagulate should be reasonably low, and that certainly prophylactic anticoagulation is a consideration. I'm on the scientific advisory group, and we'd actually done a review of thrombosis complications, and we'd basically come out saying, treat them as you would any other critically ill patient pending more data. And I'm not aware that things have changed very significantly in that domain, although I expect we will learn more. So apologize if I'm not as up to date on the thrombosis literature at the moment, because that review was a little while ago.
Okay, yeah, it's just still more to learn. We have a question. This gets back to the steroids. Can you comment on the potential harm seen and maybe using the steroids too early, seen in the recovery trial? Any thoughts on whether that might be a real signal?
Yeah, and it's not clear why, and I haven't seen the data as to why it was non-significant, but a possible trend. Like I think the hazard ratio was 1.2, that there was a less good outcome. And so whether it was a direct result of the steroid or possibly related, for example, to likelihood of opportunistic infection is unclear, because although that dose is not high, it is high enough that we would have a bit of concern for possible infectious complications. So it's an open question, but it really would support that with that little lack of clarity of risk benefit early in disease, that waiting until I simplify the disease into kind of like the viral stage and then the immune stage, and that's probably not exactly accurate, but it's not a bad shorthand. And so I would want to use antivirals earlier in infection, and later in the inflammatory phases is where the people are evolving towards a more inflammatory phase where the risk benefit of steroids would appear to be most robust. So it is an open question. And I think that if people are tempted by the data to give steroids before anyone requires oxygen, that would not be supported by the data.
Okay, great. That's really helpful. And there's kind of a corollary, a follow-up question from a different participant asking, would that be any different in a person with a history of asthma or COPD who isn't severe or critical yet? Would that lend any earlier use of steroids, or would you still feel pretty cautious about?
I think that's a really good question. I would tend to treat people who have comorbidities that may benefit from steroids differently, because in my mind, like many respiratory viruses, COVID can stand to cause worsening of coexisting pulmonary disease pathology, so asthma flares or COPD exacerbations, in which case I think I would handle them as an asthma or a COPD exacerbation as well as a case of COVID. And I think you would be able to justify using steroids in that scenario, even if the person does not yet require oxygen, although to be honest, I think they probably would be likely to be observed in a hospital setting with that pulmonary condition.
Yeah, that makes a lot of sense. Great, thank you. Okay, so this relates to the description as you gave before, which is a nice way to think about it, the viral phase versus the immune response. And so this participant is asking, would you use remdesivir for a patient who has severe COVID that's mechanically ventilated, or do you consider that just too late for an antiviral to really help, and based on the data?
Well, the data right now is a little bit incomplete because we are still waiting for the final ACTT data. Mm-hmm. I would tend to prioritize steroids in that group. And if I had, I guess, unrestricted access to antivirals, I would consider their use in that group, but I wouldn't prioritize it. I think it's likely best, it'll probably end up being best to use the antivirals earlier, possibly even earlier than has been studied so far, and the steroids later. So although everyone's tempted, I think, to treat the critically ill with everything you can think of, I think the likelihood of significant benefit based on current data is low, although I'd be open to change my mind if I saw different data.
Yeah, great. So this question ties into something you mentioned in that answer, which is the fact that there isn't an unlimited supply of remdesivir. So Aisha asks, since remdesivir is approved for moderate disease as well as severe or critically ill, but we've got, we don't have enough of it necessarily for all of that grouping, would you maybe preserve it for the moderate, since the data are less supportive and more advanced?
I tend to think that way. I think others do as well. And I was helping with a cost analysis based on current data, which suggested also that remdesivir for moderate and dexamethasone for severe is actually the most cost effective across most healthcare systems at the present time and based on just the current data. So that may evolve, but I would tend to prioritize the remdesivir for the patients who are moderately ill in hospital. Not imminently heading to the ICU, but obviously, requiring hospital support. And I would tend to want to interfere with steroids in people who are on non-invasive ventilation or in the ICU.
Great. We have another question that's related to oral antivirals, but in this case, not remdesivir. Gregory asks if a drug like EIDD 2801, which we don't have data for yet, I don't believe, were to be effective, that being an oral antiviral, do you think there'd be reason to be using that earlier and maybe even in asymptomatic cases, just to decrease the spread of disease?
I think that's a very interesting thought. If we had an active orally available antiviral, that would be the natural place, I think, to study it, which would be very early in disease, like shortly after diagnosis. We'd have to try to diagnose earlier as well. And then look and see if it changes the viral kinetics, because it might actually reduce transmission of disease potentially, as we sometimes see with influenza. And it would offer a different approach to outpatient care, which at the moment, I think a lot of places are, I'm sorry you feel unwell, go home and monitor yourself. And so I think that would be a real addition if it kind of made it past the theoretic stage into clinical practice. But of course, there's a lot of medications that look promising in vitro that don't turn out to be promising in vivo. And so we'll just keep an open mind, I guess.
Yeah, good point. We need the evidence. Mohammed has a question. Do you use remdesivir for more than 5 days? And if yes, when?
The current data really, although there's flaws with it, the current data really does reassure that 5 days is a good course for most patients. There's kind of an open question as to the more severely ill patient if extending for 10 days may offer benefit. I would say there's not really any strong evidence for that, but some people would consider if they have adequate supply. Here, because we do have a relatively limited allocation, we also don't have as much COVID as many other places. I think that we're tending to use 5-day courses in pretty much everybody because the current data would support that.
Yeah, and it doubles the number of patients that can get the benefits, and it's equally beneficial with 5 days. Great. Okay, so let me try to find these questions here. Vinod asks if you could explain the difference between pneumonitis and a COVID infection on X-ray. Is there a distinction in how those look? And would you treat them differently if the symptoms were similar?
Well, I think of pneumonitis as being a non-specific term in that it basically just describes parenchymal inflammation, and it can be infectious or inflammatory. And a viral pneumonitis, bacterial pneumonitis, and inflammatory allergic pneumonitis can all look quite similar. I think the radiologists who are in COVID areas do tend to see patterns that would make them suggest COVID over other conditions, but we also know that there's enough non-specific presentations that I would hesitate to make the call on the basis of plain film. Early on, there was some suggestion that CT scan patterns were much more specific and could be used as an adjunct to diagnosis if there wasn't availability of other measures. But I think that's less relevant in most settings now. I think now the COVID testing is more available and the radiation burden of CT is probably not justified as a diagnosis. So if someone tested positive for COVID, I would look at their X-ray and take the stance that it's likely the changes could be due to COVID and treat accordingly.
Okay, great. Thank you. Okay, so Priyanka asks about, would you recommend using tocilizumab with steroids in more severe or critical cases? Really, what are your thoughts on the tocilizumab data so far?
The data's kind of been pendulum swinging a bit in my mind, and there was some kind of promising data and quite a lot of promising anecdote, honestly. At the moment, I think the caution has been tossed into the mix because of the possibility of more significant opportunistic infections in the critically ill. And the action of tocilizumab is actually quite prolonged. And so people are presenting potentially quite late with infective complications. And so I think until we have a better understanding of the degree of benefit, it's probably best to use that in the context of a trial, because I think that has to be carefully assessed. I mean, if it helps reduce the inflammation related to COVID, but gives you a significant increase in your risk of opportunistic infection, I think that we would, it would be important for us to monitor that in the context of a trial before making a recommendation. And similar to some of the other immunomodulators, I think there's potentially a promising role for combination therapy, but it should mostly be done in the context of a trial to basically best serve people, to get the best evidence possible to move through the pandemic and treat people with the best available current knowledge.
Great. Gwendolyn asks if there's been any evidence of reinfection with the same virus, the exact same virus, which I don't know how that would be defined, because if it was the same virus, would it be true? How would we know?
Yeah, I think that that possibility was raised because there was intermittent, spates of information that people were testing negative and then positive and presumed to be a reinfection. And we actually reviewed that in some detail at one point. And what we really saw was the story would be that because the viral load is detected with a cycle threshold value, which is not reported because it's not validated as a qualitative measure. But basically, once the viral load is declining as a person is improving, but it can actually hover around the level of detection for a while. And during that time period, you might test positive and then negative and then positive again, because you're just at the threshold of detection of the test. And some people can actually have very prolonged shedding of viral RNA, even though they don't have viable virus. The viable virus is mostly gone after day 7 to 10. So those kind of neg, pause, actually were being interpreted as reinfection, when in fact they were just really low level positives that were intermittently detected. And in that case, if you were wondering about that possibility, you'd really be looking for a much lower cycle threshold, implying a higher amount of virus, so a trend towards higher virus, and sequencing the virus to see if it's actually the same one. And I don't believe that's been shown. Okay,
great. Okay, and so that actually leads into some other questions about, let me take a look here. So about retesting, follow-up retesting. So we've basically got 3 testing questions in there, and I think they're all getting at the same thing. So Joseph asks, is there a role for retesting in an individual who is positive and is still symptomatic, maybe 30 days out? And then for a non-hospitalized patient with COVID, when can they safely be reintroduced? When can they safely go back to their normal activities? I think the gist there is, what's the latest recommendations for how long to quarantine, and what does it mean if you still have symptoms past that?
Most, and we've reviewed this extensively again with our process, and most people, with the exception of the critically ill and immunocompromised, who might shed viable virus for longer, but the vast majority of people do not shed virus beyond 8 days. And as a matter of fact, epi data suggests that most people transmit within the first 6 days of symptoms. And of course, that includes maybe 1 or 2 days before the onset of symptoms. But then again, this prolonged viral load detectability does lead to some questions. And I think most places have now gone away from repeat testing because the viral load does not tell you anything about transmissibility at all. And so I routinely discourage retesting. Our guidelines are actually that 10 days after the onset of symptoms or symptom resolution is when people can return to, basically activities without being concerned for transmission. There's a bit of a nuance there, which I think could come up, which is if someone has, a prolonged convalescence and has been critically ill, they might not be asymptomatic, but their active symptoms of infection, malaise, fever, acute cough, and runny nose, and all those things should be resolved. But if they've been intubated, obviously they still might have symptoms 10 days out. So you have to take that into account. So if there's no symptoms, I think, of active infection, and it's been more than 10 days since the onset of symptoms, the likelihood of them being able to transmit infection is very low. And I think retesting is really probably not the best use of resources right now. And I would discourage retesting for that reason.
Great, thank you. Okay, so we've got a couple of participants have asked about HIV in COVID. One question notes there's been several case series showing that patients with well-controlled HIV don't appear to have an increased risk for severe COVID. Thoughts on whether this could be due to antiviral effects of antiretroviral therapy or any mild immunosuppression protecting them from the cytokine storm?
It's an interesting question, and I think I probably don't have the answer either. I know my HIV patients were all very concerned at the outset and very, very reassured. I think there's a strong suggestion that people with controlled HIV's immune dysfunction is not severe enough to really cause excess risk of severe disease. There is some anti-SARS-CoV-2 effects of some of the antivirals, particularly protease inhibitors. It's a fairly weak antiviral effect. It may play a role for some patients, but for patients who are not on antivirals that appear to have effectiveness against the virus, I think it's more just that their immune system is not that bad. And then the final idea, which I think is an interesting one, is that not all immune suppression is the same. We just did a review of immunosuppression, and aside from having an active, uncontrolled autoinflammatory or autoimmune disease, or being on steroids, or being on active cancer therapies, those three things appear to be the highest risk. Quite a lot of people on immune modulating drugs do not appear to have enhanced risk of severe disease. Of course, the data will be influenced by the fact that these people have also likely been very careful. But even when you look at people who've been hospitalized, it really does not appear to be as severe. And there's some slight implication that some immunomodulators might protect against severe disease, possibly by that mechanism of reducing the inflammatory consequence of infection. And so that'll be something to watch. But my usual thought on immunosuppression is that we should be careful not to lump it all together, because some of it is obviously more important for severe COVID, and some of it might even be protective against severe COVID. So it's quite a complex area.
Yeah, it's nuanced. That's a really good point to consider. Yeah. Okay, while we're on the topic of HIV, Gregory has mentioned, and just considering HIV maybe as a paradigm, do you think that this is an opinion question, obviously, do you think that clinical trials should be moving more quickly to look at combination therapies, maybe triple therapies, that are trying to maybe target more than just the polymerase?
I think in my mind, there's some differences between an acute respiratory viral infection and a chronic viral infection that actually integrates into your own cells in terms of the consequences, because in a lot of, I guess, to oversimplify again, persistent infections that can relapse and recrudesce later, I think the consequences of monotherapy can be severe, because you might basically just be buying time for the pathogen to become resistant to your therapy. So we saw that with tuberculosis. Then, to our embarrassment, we saw the same thing with HIV. And I would not necessarily anticipate the same issue with coronavirus, which is an acute self-limited infection. We do not have a lot of concerns about resistance development during the early phase of infection, possibly because the active virologic period is relatively short, it seems. So I think the consequences are different. It might be the case that a combination of antiviral and immune modulating therapy might be beneficial for people, or that combination antiviral therapy might actually bring down the viral load more quickly. But I don't know if I would consider that as high a priority in this setting as I would in some others.
Yeah, thank you. That's a good point, that's a resistance fighting mechanism in HIV for longer term infection. Okay, let's see. Okay, we're going to go back to steroids briefly here. Agnes would like to know if you would use steroids in a patient with diabetes for treating their COVID.
What's interesting is I think we might find out more from the current trials, but I think that was one of the features that, for example, made the Oxford investigators tend not to enroll them in that pragmatic trial, because they were concerned about the potential downside of steroids. Having said that, that would suggest we might have less data in that patient population. but people with diabetes definitely have enhanced risk of severe outcomes. And so I would probably myself accept that it will make glycemic control a challenge and still give it to reduce the likelihood of severe outcomes in someone who has, oxygen requiring and progressive COVID disease. And that would imply a certain amount of, I guess, healthcare burden, because of course, monitoring that can be a little bit challenging. But I think that my current take would be that I would offer steroid therapy and do enhanced monitoring. Although it is true that we probably have less data on that in the diabetic subgroup of patients.
Okay, great. Thank you. Okay, I think we have time for one more. So Margaret asks, and we touched on this a little bit, I'm not sure if this is known, but how strong are the data for either antibody generation or T cell response in asymptomatic patients? So I guess
that pendulum has swung a little bit. So there were a couple of publications with smaller numbers that suggested that people with, I would say asymptomatic or post-symptomatic, because let's be honest, people don't always pay attention to minor nuisance symptoms, but low-level symptoms might not have as robust or as long-lasting immune response. But then there was just a report from Iceland which suggested that that is not necessarily an issue, and that people with any type of symptoms appear to have a similar serologic response, and it appears to have similar durability. So I think there's a bit of question right now as to whether or not the immune response to minimal or mild disease is the same. And so that actually might have some implications as well when we're looking at the use of vaccine, honestly. But at the moment, I think it's not clear. And there's some piece of evidence on either side for that. And I think that we will continue to learn more, because I know a lot of places, including here now, we do have access to reliable serologic testing. And I think that we will be getting a lot more information about serology in the next few months.
Okay, great. Thank you very much, Dr. Saxinger. And thanks to our listeners. As a reminder, to view the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.